Czym są rejestry medyczne i jaka jest ich rola w systemie ochrony zdrowia?
Medical registries are a tool. The thing that we really need to talk about is how do we combine access for patients to innovative, expensive medications with the budgetary constraints of the states, not only in Poland, but also in Italy, where I come from, in UK, where I've been living many years. That's a common problem. Oncological diseases, hematological diseases, osteoarthritis, and many others are going to deliver for the patients and for the doctors extremely effective drugs over the next 10 years. They've done it already. How do we combine these two things? Now, the main tool that has been developed, I have to say, starting in Italy in 2005, 2004, but then is now going all around Europe and the US, are the so-called managed entry agreements, which are agreements which guarantees the effectiveness of a certain drug for a particular disease in exchange of an earlier access for the patient to that medication. So in effect, the principle is very simple. Is the principle you would apply in the supermarket. You pay if you're satisfied with the result. Now, in order to do that, you need a technical tool, which has to be highly sophisticated in its background, but it has to be extremely simple and quick to use for the medical doctors, for the oncologists. Now, these tools are the registries, but really we're not talking about here IT and technicalities. Here we're talking about the health of patients and their access to innovative therapies.
Jakie są zatem kluczowe czynniki sukcesu w procesie wdrażania rejestrów medycznych?
If we're talking about, for example, oncology, the first and most important thing is the dialogue and the agreement with the oncologists. Doctors must believe that this is a simple tool that will help him or her and its patients. The second aspect is the agreement with the authorities to have a transparent, criteria-based flow of information within the framework of privacy protection. In very practical terms, the only one in all this process that has access to the name of the patient is the treating doctor. But all other stakeholders, primarily the payers, so the insurance houses, they must have, and they do have, not only the ownership of the system, but also the access to all other information at any level of aggregation that allows them to manage appropriately the resources in their hands. So agreement with the oncologist, agreement with the authorities. The technical aspects, the introduction of the registry, let me tell you, is by far the simplest.
Jakie są instrumenty dzielenia ryzyka w systemie ochrony zdrowia?
Yes, a little bit of taxonomy. When I talk about managed entry agreements, this is a whole category of agreements at the disposal of authorities, of doctors, and industry, of course. Part of these managed entry agreements are the risk-sharing agreements, which are agreements whereby for innovative drugs, where the clinical practice is limited, the state is prepared to share the risk of failure in the idea that it is in any case a progress in the treatment of that disease. So very practically, a risk-sharing agreement is an agreement by which should the patient at this control time fail, the state will receive back usually half of the cost of the therapy in that period. The so-called payment by result, or called PBR, is an agreement by which at failure, in case the drug fails, the state receives 100% of the money back for the period under which the patient has dropped out of therapy. There is a third category of managed entry agreements, which is called cost sharing. And these are used when it's difficult to identify clear endpoints. Solid tumors, they have most of the times clear biomarkers, and it's relatively easy for the oncologist to assess if the patient is, if the disease is progressing or not. Other diseases, they go under a so-called cost sharing, which is effectively a financial discount without any major link to the performance of the therapy.
Czy rejestry medyczne i podziały ryzyka mogą być skuteczne na przykład w hematonkologii?
Absolutely yes, and there are already examples in Italy which are very recent. They're exactly on CLL and MCL of products which are register based, and they use a managed entry agreement of the cost sharing type based on registers. So there are already clear examples in this field.